respected chairperson, and again, ladies and gentlemen. So Nasik continues to surprise us because we have seen so many regional CMEs, but this CME of this magnitude, which has been well conceived and executed very nicely, probably the best one which we have seen. We have never seen such a regional CME in such a magnitude, and thanks to the IMA and ASIC for making it possible. It's really surprising, even if not also, it is past 8 p.m., still the hall is, so many people are there to interest. To complement your so many good things, I will compress my talk. It is already 15 minutes past. But this is very important. It's eosinophilia is not a disease, it's a syndrome seen in many diseases. What is a pragmatic approach in the clinical practice? So I will try to make it very short as possible. So before going for, I will introduce some of the terminology. Eosinophilia is defined when the absolute eosinophil count is more than 500. And the blood hypereosinophilia is defined when the absolute eosinophil count is more than 1500. The tissue hypereosinophilia is any one criteria. If the eosinophil cells is more than 20% of the all mononuclear cells, or if there is a tissue infiltration by eosinophil which is markedly increased, appreciated by one of the senior histopathologists. So that's the definition. Third is if there is an extensive extracellular deposition of the eosinophil derived by proteins demonstrated by immunohistochemistry. As you know, eosinophil has many proteins. If you find it any protein, excessive deposition in the extracellular tissue done by the immunohistochemistry, that is also one criteria. And hypereosinophilic syndrome is a generalized term which used for any region, irrespective of the etiology. If the absolute eosinophil count is more than 1500 per cubic millimeter, we call it as HES. And there is interesting, like MGUS, we have hypereosinophilia of unknown significance. Means here the eosinophil count is very high, but without any clinical symptoms. They are very benign, and rarely they progresses and may not require the treatment in most of the cases. Like monoclonal gammopathy of unknown significance. Similarly, also you have HEUS. So today I will be saying that HES means hypereosinophilic syndrome. The absolute eosinophil count more than 1500 for any reason. We look at a case history, 48 years female, fever, lymphadenopathy, splenomegaly, myalgia. Her CBC looks like the tails count is 98,000, absolute eosinophil count is 70,000. The chest and CBS are normal limit, is very simple. It fits to your diagnosis of clinical syndrome, HES. So how you are going to approach this case? So if you look at the hypereosinophilic syndrome, the diagnosis of HES is, if the eosinophil count is more than 1500, I have already told you, or marked tissue eosinophilia, the criteria I have already told you, with clinical manifestations attributable to the eosinophil, where no alternative cause is seen. So both the criteria needs to be fulfilled. Either eosinophil count more than 1500 or marked eosinophilia with the clinical symptomatology without any alternative possibility, your diagnosis is HES. So before going to the management complications, if you look at eosinophilia, what is the main pathophysiology or pathogenesis of eosinophilia? Eosinophilia causes tissue fibrosis, thrombosis, vasculitis, and allergic inflammation. So these are the four common pathophysiology. And pathogenesis is still, and this HES or this eosinophilia also can cause life-threatening complications in certain situations. The specific biomarkers which can lead to these complications we do not know, and we consider it's an aggressive disease with a poor prognosis if any one of the criteria is there. If the absolute eosinophil count is more than 1 lakh, or if there is a features of the heart failure or features of the myeloproliferative neoplasm, or there is a resistance to the corticosteroid therapy, any one criteria, it indicates probably the risk is very, very high, and it may be considered as one of the medical emergency also. So while dealing with a HES case, the factor influencing the pathogenesis or the magnitude of the morbidity and mortality, it includes the number of the eosinophils present in the tissue, the location of the site of the lesion, the degree of the activation of the eosinophil, and of course the underlying etiology. So it is the combination of all the parameters which determines the overall impact of the HES. The DD I will skip. It can be allergic disorders, It can be drug hypersensitivity. There can be various infections, helminthiasis, ectoparasites, protozoa, fungal, and viral infections. I think it's all there in the textbook. If you look at to continue, you can have a neoplasm like leukemia, lymphoma, adenocarcinoma, immunological disorders. You can have a lot of miscellaneous like radiation, interleukin therapy, and hypoadrenalism, and rare eosinophilic disorders. So these are the causes or the differential diagnosis of HES. These are the investigations which are required. It is there in the books, the textbooks. I will skip, but only I will highlight that in all cases of HES. So these molecular tests like PPL1 or PDGFR should be done by FISH or by RT-PCR, and along with all the conventional investigations, I am sure you can follow any textbooks. And for any specific clinical variant, if you are finding like it could be or the patients with features of the myeloproliferative HES, which I will call it later on how to categorize myeloproliferative or the lymphocytic HES. If you are suspecting it could be a myeloproliferative HES, you should go for the BCR-ABL, PDGFRB, and all these JAK2 and KIT mutations. If your clinical symptomology and parameters suggest it could be lymphocyte variant, which I again call, which I will enlighten you on the later on, you should go for the PET scan, lymph node biopsy, or EB viral load. So these are the specific investigations we should do depending on the clinical scenario. Yes, depending on the clinical features, all other parameters, to have a pragmatic and bedside approach, we can divide the HES into the 6 clinical variants. One is your myeloproliferative or MHES. The second is your lymphocytic variant. The third is overlap. Then fourth is associated HES. The fifth is familiar. And sixth is idiopathic. So all the HES, so depending on their history and your clinical science and various investigations from the therapeutic point of view, from the clinician's perspective, it can be divided into these 6 clinical variants. So let's come to the first. So myeloproliferative variant is one of the most common one. It's a clonal eosinophilic involvement. You can call it as a eosinophilic leukemia. You will find, as the name suggests, you find the features of the myeloproliferative neoplasm, which includes splenomegaly. You find the eosinophysis and precursors of the eosinophils in the peripheral blood. You can have eosinophil myelocyte, metamyelocyte, even myeloblast also from the eosinophilic origin. And it's an aggressive, high mortality if not treated. And most importantly, if you look at in 80% cases, the PDGFR molecular abnormality is positive, which you can know by the either by the FISH or by your real-time and PCR technology. Besides, in PDGFR negative also, all these JAK2 and other molecular abnormality also still you can detect. And most importantly, it's imatinib sensitive. In low dose from 100 to 400 milligram, it can cause rapid remission, including molecular remission also. So myeloproliferative variety will find splenomegaly, all the features of the myeloproliferations along with the PDGFR positive and imatinib sensitive. These are the salient features of the MPN variety of HES. Now second is lymphocytic variant. It's again clonal, is one of the eosinophilic leukemia. Here what happens? You have a abnormal or clonal lymphocytes which produces these cytokines and interleukin-5 that drives the proliferation of the eosinophil to a particular tissue. You have a high prevalence of skin and soft tissue manifestations. IgG and interleukin-5 is high, where you can go for investigation, you can confirm. This is an indolent course. In 5 to 25% of cases, it can convert to a lymphoma. So this lymphocytic variant is more of a lymphoproliferative disorders. You have clonal abnormal lymphocytes, which produces cytokines, interleukin-5, which causes proliferations and chemotaxis or the migration of the eosinophil. The third point is that you have a overlap HES where it's restricted to a single organ system with increasing absolute eosinophil count as per the criteria. It can affect, as for example, it can affect the GI tract or the lungs or the cardiac tissue or the liver. If any organ is only involved, along with a high eosinophil count, we call it as a overlap HES. The fifth is your associated HES. it simply is, it's a name also, it's related to any other primary etiology. Means if the absolute eosinophil count is 1500, it about 1500, in the setting of a primary etiology, we call it an associated HES. And as the name suggests, the primary management is you address the primary etiology with or without steroid. That's the way you should deal with associated HES. And the last is, or the fifth one is the familial HES. As the name suggests, the multiple family members are affected, usually autosomal dominant, usually asymptomatic with a lifelong high eosinophil count. And they are very benign, they don't progress, they don't cause any medical emergency, and in most of the cases, no treatment is required. That's the story of the familiar HES. The last one is idiopathic. As you know, in any setting, in spite of your all characterization investigations, you may not be able to categorize to which of the five clinical variant is caused or it goes. The last one is idiopathic, so not categorized to any of the above five which I discussed. So no etiology could be detected. It is probably commonest is seen in more than 50% of HES case. And it can involve even multi-system involvement. It can progress. It can cause also medical emergency. It's not the benign the way the familial type is there. So hypereosinophilic syndrome, unknown significance, I have already told you. I think I will skip that. So now the second portion is how to approach. One to diagnose the HES. One to categorize to which clinical variant it belongs. So now what should be the approach? The first step is you decide whether the patient needs treatment or observation. As I already told you, you have a familiar HES or HEUS. They are very benign, they are very stable, they don't progress. So if this is the character or if this is the clinical variant, you have to only wait and watch. So no treatment is required. The second step is that there are certain conditions where it can be a medical emergency. So you would have evaluated at the clinician's point of view. So is there any need for urgent therapy? If there is any need for urgent therapy, then you should give that urgent therapy as a medical emergency, and simultaneously you should go for evaluation, your history, clinical findings, investigations to categorize into any of these 6 clinical variants is there. So as a second step is decide whether it is a medical emergency and the patient needs urgent treatment or not. The indications for the urgent treatment, or if there is any medical emergency, if there is any one criteria, if there is a cardiac, neurologic or thrombolytic complications, or if the absolute eosinophil count is more than 1 lakh, or if there is a rapidly increasing absolute eosinophil count in hours, any one of the criteria fulfills, it could be a medical emergency and it can cause devastating complications unless it is addressed. So that's the indication. So urgent therapy, how we are going to go for urgent therapy? As a urgent therapy, the choice is you can go for the prednisolone in the usual dose, along with the IV methylene prednisolone single bolus dose about 1 gram, which is roughly comes about 2 milligram per kg. That's the way preferred one. And if you are suspecting it could be a strangulation infection, ivermectin should be added. And adding these steroids along with IV methylprednisolone, you should concurrently go for your clinical evaluation and other investigations to categorize to which exactly, so that clinical variant it belongs. Now the third step is, or the next step is, if there is no improvement, or if the symptoms or there is no improvement, or the eosinophil count does not come down in 2 days, or there is a requirement of the prednisolone more than 10 milligram per kg as a maintenance therapy, that is the way you should look for the other possibility. The other drugs which you should consider adding a second drug to your steroid or IV methylprednisolone is the addition of the second line agent. You have to select. So the selection of the second line drugs or second drugs depends on the clinical presentation, the clinical variant which it belongs, organ involvement, and side effects and profile of the drug. These are the 4 parameters which you have considered while selecting the second drug other than the steroid. These are the guidelines which I have given. If you are having a myeloproliferative HES, as I have told you, they are super sensitive to imatinib. You have to add imatinib in a low dose, 100 to 400 milligram. If it's a lymphocytic or it's idiopathic, the drug of choice is interferon alpha. You can go in the say 3 million units daily. If it's a idiopathic or vasculitis or lymphocytic driven, still you can give the cyclophosphamide. If it's overlap HES, including the involving any individual organ, the local steroid or the topical steroid is the drug of choice. If it is associated HES, I have already told you, address the primary etiology. If it is a familiar or HEUS, no treatment is required. If it is still idiopathic steroid resistance, there is no standard treatment. You have so many reserve drugs, starting from hydroxyurea, interferon alpha, vincristine, cyclosporine, and methotrexate, and so on. You can use as any combination because there is no evidence-based guideline to tell you which drug is better or which drug is inferior. So this is the standard way how to approach for that. So dosing and duration of steroid is that you taper slowly once the symptom improves or the absolute eosinophil count becomes normal. Or second agent, if the requirement is more than 10 milligram of the prednisolone as a maintenance therapy, or there is serious side effects of the steroid depending on the guideline which I have told you. Now, what's next? So the fourth step is, if still the patient is symptomatic or the absolute eosinophil count is still maintained at the high level, you can use a sequence. There is no standard therapy. These are all reserve drugs as a fourth line drug. You can use hydroxyurea, imatinib, interferon alpha, cyclosporine, and vincristine, irrespective of the clinical variant. As I told you, in the emergency, you have to use the steroid. As a second line, I have given you free for second line, depending on the clinical variant. If in spite of all the other things are not improving, so these are the reserve drugs which can be used in any combinations depending on your choice. So the algorithm of HES, that's the last content. If you have a presumptive of the blood eosinophilia or tissue eosinophilia, you check the clinical manifestations and the history and check whether there is any medical emergency or not. If the potential life-threatening infections is there or not, the criteria I have told. If yes, then IV methylprednisolone along with IV ivermectin and prednisolone should be given. Then concurrently you evaluate and try to categorize to which one clinical variant it belongs. If there is no medical emergency, no need to start the steroid or IV methylprednisolone. You can evaluate and then accordingly depending on the clinical variant, which you can choose your preferred drugs. If there is no clinical manifestations or if there is a secondary causes, if there is no emergency, if there is a obvious secondary causes, you treat the secondary causes along with the supportive therapy with the steroids and the patient may improve. That's the algorithm. The second is that if the patient is a clinical stable HES, same thing, same algorithm is that you don't have to add the IV methylprednisolone. You concurrently evaluate depending on your clinical variant. You can start your therapy. So this is my last slide. If there is a steroid refractory HES, if you are suspecting it could be a myeloproliferative HES or idiopathic, you can start with imatinib. If it is still idiopathic, you can consider it could be lymphocyte driven. You can go for interferon alpha, hydroxyurea, interferon alpha. So that's the way you should approach with the steroid resistance HES. I think that's all. So this was 63rd HematCon will be held in Kolkata from 3rd to November in Kolkata. You all are invited to join in a big number. The way you have made this event a huge success. So thank you very much for your attention.